Hello and welcome. So this video is a training video for the paediatric early warning scores to be implemented into Clacton UTC. So what is the PEWS? So the PEWS is designed to help clinicians detect early signs of deterioration in the child. It's this single common language that you can use between organisations. So currently Colchester and Ipswich Paediatrics have this in place and have been using it since September 2024. PEWS is a system that comprises of a chart and then it also has an escalation process with it. We will design your own escalation process for Clacton UTC to meet the needs of your area. The chart was originally designed by NHS England as part of something called the SPOT programme, and the idea of the chart is that deterioration can be identified based on three things. So based on the physiological assessments that you will take of the child, based on your clinical intuition, and then based on the parent information that you receive. A total PEWS score will be created, and this score will help guide clinical decisions, but it will not replace clinical judgment. So this is what a PEWS chart looks like. There are age-specific charts, and it is a three-folded booklet that opens up like this. The aim for the Clacton UTC will be that you will have these copies of these charts laminated in your areas so that you can use this for your reference. Because you are paper-free, you will then put in the PEWS score into your online system that you use. So there are 4 age-specific charts, so please make sure you are using the correct chart to calculate your PEWS score. So each chart is color-coded according to the age that it is. They've also got some visual aids, so some pictures at the top of the chart of a baby, of a child, teenager, etc., to enable you to identify the correct chart. Anybody who is pregnant or suspected to be pregnant, then you need to calculate their observations on a maternity early warning scores, as their physiology will be different. With all of these age-specific charts, they do have different parameters set. So this is the reason why you are using the different age-specific charts. So what is it that contributes to the PEWS score? So respiratory rate, respiratory distress, the child's saturations, how much oxygen they're receiving, what their heart rate is, what their blood pressure is, and their capillary refill time. Other information that you will gather, but you won't necessarily contribute to the PEWS score, is the child's temperature, any parental concern, any clinical concern, their pain score, and any additional risk factors. So the PEWS works with a scoring system, as mentioned, and on the right-hand side of this screen, you will see that there's a reference table showing the numerical value that each colour scores. So a white is a 0, yellow is a 1, orange is a 2, and pink is a 4. So at the top of the PEWS chart, there is a box saying additional risk factors. Now this will be used very differently in Clacton UTC than it is within the acute trust, and this is simply because you don't have the paperwork, everything is digital. But what I would like to see from staff in Clacton UTC is that when you are assessing your child when they first present to you, is whether they have any of these additional risk factors. So for example, if your child comes in and they have a tracheostomy in place, you are then thinking, do you have the additional help needed in an airway emergency? Do you have the additional equipment needed to deal with that airway emergency? And you would highlight any additional risk factors in the child's digital notes when you first assess them. I want to explain to you something called the carer question, which is at the top of the PEWS chart, so that you are aware of what it is and why it's there. So the PEWS chart was designed as an inpatient chart by the NHS England. So that means that they designed it to be used in acute hospitals, inpatient areas only. However, they have said that this can be used in other areas if we wish, if our trust wishes. And so this is why we are bringing this out into Clacton UTC. Now, with this carer question, what should happen in inpatient acute hospital areas is that every single time the observations are done, the parent is asked, "How is your child different since I last saw them?" by the nurse. The parent will then answer, and then from that answer, the nurse has to decipher whether the parent is implying that the child is worse, better, or the same since they last saw them. And then they would document it down in the bottom of the chart as worse, better, or the same. If the parent is implied that the child is worse, the next step then would be that the nurse could escalate that child according to this worse. And they don't have to have a raised PEWS score to be able to escalate to the doctor. They can just use that as a source of escalation. Now, how we are going to get this to work in Clacton UTC. So this is going to be very different because this is the first time that you are seeing the child and their parent, and the child or parent is going to be concerned when they first present to you. What we want to see, we don't necessarily expect you to fill out this question initially when you first triage them, but what we do want to see is that you are taking into account what the parent is telling you. So if after you've started treatment and they happen to be in with you for longer than you would expect, the parent is still saying to you, "I'm concerned about my child. I think they're deteriorating. I'm really worried about them. I think they need to be seen by a doctor. I think they need to go to hospital," then we need to be listening to those opinions. So what we can say, so even if their PEWS score is low, what we want to see, if their parents are implying these, so they're saying that my child's deteriorated, they need a review rapidly, then you can be calling the doctors in Colchester and explaining the situation, and then take it from there. So have a discussion with the doctor about this child. Okay, so we'll get on to the first bits of the chart. So the chart is actually laid out in an A, B, C, D, E manner. So the first section is airway and breathing, and it takes into account these 5 physiological parameters. The first one is respiratory rate. So you are going to take the child's respiratory rate, and then you are going to document. Usually you would document it on the chart, but you will need to document it in your notes so for example, this example they've given us, the child's respiratory rate is 47. And so because it's 47, it sits within the orange zone there. So you will need to use the color codes on the PEWS chart, on the physical PEWS chart that you'll be given. So this one sits in the orange, so that will be a 2 towards their total PEWS score. Next, you'll be calculating their respiratory distress. Now, these respiratory distress parameters will be different depending on the age of the child. So you can see on this slide here, I've set them out. So 0 to 11 months is on the left-hand side, up to 13 plus years on the right-hand side. So you are looking to see if your child is demonstrating any respiratory distress. So do they have, let's say you have a child that's come in that's 7 years old and has tracheal tug and accessory muscle use. So I'm going to go to my respiratory distress chart, and I'm going to have a look, and I'm going to see that my accessory muscle use is a mild, and the tracheal tug is moderate. So I would score my child as being in the moderate zone, in the worst one. And so this is in the orange section. So this is a 2 towards the total PEWS. So far I have 2 for the respiratory rate and 2 for the respiratory distress. So next you are going to take the child's oxygen saturations and document this. So anything 95% or above is in the white section, so it scores a 0. Anything 92 to 94% sits in the yellow section and scores a 1. And anything 91% or below sits in the pink section, so scores a 4 towards their total PEWS. So if we look at the example patient we've given you, their saturations are 93%. That sits in the yellow section, so that scores a 1 towards their total PEWS. So far we have 2 for respiratory rate, 2 for respiratory distress, and now we have a 1 for oxygen saturations. So that's a 5 in total. The next section is regarding oxygen delivery. So if you have a child that comes into Clacton UTC that is on room air and you don't use any oxygen on that child, you would document this. This is the air, how you would document the air, but this sits in the white zone, so you wouldn't produce any score towards the total PEWS score. So you would just move on to your next question on the PEWS. If you did put some oxygen on the child, you then need to decipher how the child is receiving that oxygen. So they've got two different categories. They've got delivery methods here, which is your standard lower dose oxygen, so your nasal prongs, face mask, head box, or non-rebreathe. And then you've got your respiratory support devices, which is unlikely that you are going to use this when the child is with you, because I don't think you've got access to this at Clacton UTC. So this is for your higher flow oxygen, so high flow BiPAP or CPAP. So if we just first start off of these delivery methods, so if your child is getting anything with these delivery methods, so the lesser oxygen, then you would take your score from how much oxygen they're receiving. So I'll give you an example. This child here in this first column is having 40% via a face mask. So on the graph, it's plotted as 40%. That sits in the orange zone. So that scores a 2 towards their total PEWS. This child, as I've mentioned in the second column, is on air. So that's in the white zone. So they're a 0 towards their total PEWS. I'm just going to jump to the fourth column here where the child is on nasal prongs. Now, if you do have a child on nasal prongs, which you might well have, this is obviously documented in litres per minute. So this child is receiving 2 litres. Now, if you trace up to the PEWS chart here, you will see that these are all percentages down here. We don't expect you to calculate the litres to percentages. So what they've done is they've given you all of the litres per minute down the right-hand side of the chart. So you need to have a look at that. So you can see here 2 litres is between the yellow and the orange. You would then trace back here, and that is where your 2 litres in. And actually, when you fill out the paper chart, or when they do in the acute trusts, what they do is they do a cross, which would indicate litres per minute, and they do a dot, which indicates percentage of oxygen. So I can see here, so it's actually a bit of a tricky one because it sits between the two, and then you think, oh, which one do I score as? You always score with the worst. So if anything is sitting between two parameters, score is the worst. So this is sitting between yellow and orange. I'm going to score it as an orange. So that's 2 towards their total PEWS. Okay. This section here, I will explain, but you won't use this in Clacton. But if by any chance, for some reason, your child in Clacton UTC is being put on high flow, for example, then this is different in terms of the score towards the total PEWS. This will always score a maximum of 4. It's actually documented up here. So this RSD code, that's this respiratory support device. So if the child happens, this child is on CPAP here. So if you happen to put them on CPAP and they're on 70%, their score will not come from the percentage of oxygen they're receiving. It will come from the fact that they're on an RSD, a respiratory support device. So they score a maximum of 4 no matter what. So if this child, for example, that is on CPAP, they start at 70%. Let's say next time you do their observations, they then drop down to 40%. You've managed to wean them a bit. They would still remain a 4 towards their total PEWS because they still are receiving a respiratory support device, even though their oxygen has dropped into a new scoring level on the oxygen. Okay. So hopefully that makes sense. It's a bit one of the more complex items on the PEWS chart. I think the main things to remember, so if your child is on air, that's a 0 towards their total PEWS. You can go on to your next one. If you've put them on oxygen, just make sure you document in your digital system how they're receiving it, what percentage or litres per minute they're on, and then calculate whether that litres per minute or percentage sits in the yellow, orange or pink section. Okay. So you're moving now onto the circulation section of the PEWS chart. So this consists of the child's heart rate, their blood pressure, and their capillary refill time. So you document the child's heart rate. You manually take their heart rate over their minute, and then you would Consult your PEWS chart to see where this sits in the scoring system. So the example they've given us here on this slide is the child's heart rate is 120, so that sits in the yellow zone. Here we go, it will actually sit in between the white and the yellow zone. So as I mentioned previously, you're always going to put it into the worst section. So this does sit in the yellow zone. It scores a 1 towards that child's total PEWS. Next, you move on to blood pressure. The aim for the Clacton UTC, we want everyone on triage to attempt a child's blood pressure. It's really good to have that baseline blood pressure. Should the child deteriorate, you've got something to look back on and work towards. Now, we have got this PEWS chart has 3 different codes that you can use if you're not able to get a blood pressure for some reason. We'll start with if you are successful in getting a blood pressure. So this example they've given us here is 112/60. How you would score this is you would score it from the systolic. So you can see here the 112 systolic sits within that yellow zone here. So you would put that as a 1 towards their total PEWS score. Okay. NHS England also want us to record the position of where the blood pressure was taken. So, for example, was it taken in the left arm, the right arm, left leg, or the right leg? Now, the codes. So I've just magnified that bottom section here so you can see the codes a bit more easily. So these are the 3 codes. So there's NCO, U0, or U4. Now, the NCO means that you have not attempted and you are not concerned. So you would use that, not on triage because you're always going to try and attempt, but you would use that for your subsequent one. So let's say your child comes in, you've done a blood pressure when they've first been triaged, and let's say they're still there an hour later, you retake their observations and you think hemodynamically they're not unstable. I'm not concerned about them hemodynamically, so I'm not going to attempt a blood pressure this time because I got it on triage and it would just cause extra distress to this child. So I am going to put in my code of not attempted, no concern, and that's NC0, and that scores a 0 towards their total PEWS. Okay, so that's your first code that you could use. Your second code that you could use is your unsuccessful attempt, no concern. So this one here. So that's a U0. So what that means is this might be used on triage. So you've gone on triage to try and take a blood pressure on the child, but actually the child is pushing you away, not letting you near them. It keeps crying when the cuff gets blown inflated, and so you stop doing the blood pressure, and actually you are not concerned about them hemodynamically. You don't think they're deteriorating, you don't think there's a problem with their blood pressure, so you can then put down your code of U0. Okay, and again, because you're not concerned, this scores a 0 towards their total PEWS. Your third and final code that you could put down is your unsuccessful attempt, but you are concerned. So you've gone to try and take a blood pressure. Maybe the blood pressure cuff has inflated, come back down, but actually not giving you a reading because it's so low, or again, the child isn't letting you, but you are very concerned that this child is unwell. Maybe they're tachycardic, maybe the cat refill is slow, etc. Maybe they're deteriorating otherwise. So because you're concerned, that's going to score a 4 towards their total PEWS. So then you would use that code U4 for this section, and you add the 4 on to the rest of your PEWS score. The last one is the capillary refill time. So this is looking at the child's central capillary refill and recording this in seconds. Now, it's really important that we use seconds to document this and not just saying it's above 3 seconds. So the 2 parameters that they've got on the chart is anything below 2 seconds will be in the white zone, and anything more than 3 seconds will score a 2 towards their total PEWS because it sits within the orange zone. So please make sure if it is more than 3 seconds that in your digital notes you are documenting how many seconds it is, and please do a central capillary refill because then we're standardizing the care throughout the trust rather than a peripheral. The next section of the chart is the disability and exposure, which includes taking the child's temperature, their pain score, their AVPU, and whether they are at risk of sepsis. So you can see on the PEWS chart that by now, once you've got to this point in the chart, you will have calculated your PEWS score up. So which means that the temperature, pain, AVPU, and sepsis do not contribute to the final PEWS score. However, we want to see that the AVPU is taken every time that the child has their observations done, and their temperature is taken every time the child has their observations done. The blood glucose and the pain score, these can really be led by your local environment, and whether you feel that the child needs these, then you would take these as you see fit. So the AVPU you would put in this box here, and then your temperature, you would take the child's temperature, and like I say, it doesn't contribute to the score, but you're looking really to see whether they sit in that red or that blue section, and if they do, then you need to be thinking about whether they are displaying new symptoms, new signs of sepsis or septic shock, and then you could write in yes there. If you're considering that your child does have symptoms of sepsis, they do have on the new PEWS chart a list of symptoms to aid your decision making. So this is really for your reference there. So think, could this be sepsis? So if your child is displaying any of these symptoms, it's worth getting them escalated and reviewed, and have a sepsis screen. So just moving on to the other questions that are on the chart, so this is down the bottom of the chart once you've calculated your PEWS score. So you've got the clinical intuition question. So this is really just asking you, are you concerned? Have you got that gut feeling that the child is just not right despite a low PEWS score? And so then you can put yes in that, and you can use that as an escalation tool to escalate to whether it be to the ACP or to into Colchester that you have that clinical intuition. So the next further down is something called the trigger criteria and the escalation level. So this is really now thinking you've got your PEWS score, you've got all the information you need. Are you going to escalate? So now there are 4 reasons why you might escalate a child. So these are written here on that left-hand side. So the 4 reasons are: there is a specific concern. So I'll go through what that one is in a second. The carer question, clinical intuition, the PEWS. So the PEWS is the easiest, and that's traditionally why we would escalate a child. So if the PEWS score is high, then we are going to escalate them. But there are other ways in which we can escalate. So the clinical intuition, so that is this question. So if you do have that gut feeling, that's another way you can escalate. So another way which you can escalate is the carer. So do you remember at the start of this training video, we spoke about that carer question and listening to what the parent has said and their feelings. So if that parent is saying that they feel that their child is worse despite the treatment that you've initiated, then you can escalate according to that. And then the final one is the specific concern. So what this means is this is to do with your sepsis and to do with AVPU. So if the child's AVPU has changed, because remember that is not counted within the PEWS score. So if the child's AVPU has changed, or they are displaying new signs of sepsis or septic shock, then this is another reason why you might escalate, even if the PEWS score is low. So what you'd write in this section here is you'd write your trigger criteria. So you might write P for PEWS, that's the most commonly used one, or you might write CI for clinical intuition, or you might write a few of them because there might be you have clinical intuition and the PEWS is high. And then you want to look at what the escalation level is, and I will go through what that is on the next few slides, and that uses the escalation pathway. This section here is really for you to write down when you have escalated the child, who you've escalated to, the timings that you've escalated them, and the times that, it says here, time that clinician is informed. So you would have the ACPs that would come to you. You wouldn't have the doctors that come over, but you could document in your digital forms when the ACP has seen the child, when you have contacted Colchester, and when they've been accepted. And then you could also contact when you've rung 999, when 999 have the ambulance has arrived to collect the child. So all of that information you need to document. And then of course, obviously they've given a space here on your paper chart for your signature, but that will coincide with on your digital site. This is the escalation pathway that sits at the bottom of the PEWS chart. Now, this was designed by NHS England as we've said, primarily for use in the inpatient acute setting. So a lot of the escalation pathway, so this section here, will not work in the area that you work in. However, what this will be good for you to reference is it will give you the reasons of why you can escalate a child. So these are the 4 reasons why we can escalate a child. So the specific concern, any clinical intuition, the carer question, or the PEWS score. It will also be good at reminding you about the levels of escalation. So the levels of escalation are low, medium, high, and emergency, and what contributes to each of those. So for example, a child that has a PEWS score of between 5 to 8 sits in the medium level of escalation. A child that is more than 13 PEWS score sits in the emergency. But then when we think about the specific concerns, so this means the AVPU or the sepsis, then they have put these into categories. So any child with a new suspicion of sepsis is put into a medium level of escalation. Any child where they've got a change in AVPU, so they are only responsive to voice, or there's a new suspicion of septic shock, this puts them into the high level of escalation. For this one here, if they've got a change in their AVPU, maybe they're only responsive to pain or they're unresponsive, this puts them into the emergency level of escalation. When we look at our clinical intuition, this escalation pathway is really good for helping us guide what we're going to do with our intuition. So they've given statements, 4 statements for the clinical intuition, what you need to do. So if you are concerned about a child and you would go and have a look at this chart, look at the escalation pathway and see where it is that your concern fits. So is it that you think nurse clinical concern that patient needs a rapid review irrespective of PEWS? So is that how you're feeling? In which case, put them into the high level. Is it that you're concerned that the patient needs emergency review for a life-threatening situation? Then put them into the emergency level of escalation. However, if you think, yeah, I am concerned, but I just think they need to see the ACP here, then we would put them here into the patient needs a medical review irrespective of PEWS. Okay, so that's a medium level of concern. The same with the carer question, really. This is the carer question. They've also given us 4 statements. And what we do, if we are listening to what these parents say about their child, we would then consult this to see, okay, so where does what their parent is saying, where does this sit on here? Is the parent saying that the child has collapsed or significantly deteriorated, in which case I'm going to put them in that emergency level of escalation. So it might be that their PEWS is 5, but the parent is saying, no, they're not right, they've significantly deteriorated, we'd put them there. Okay, so that's why this escalation pathway is really useful. Now, we have devised this section here is really what you should be doing in response to those. This is the part that we've kind of worked to try and make it more appropriate for your area. So you'll see that on the next slide. This is your PEWS escalation pathway that is for the Clacton UTC. This is one that we have devised at ESNEFT and has been specifically designed and tailored towards your needs at Clacton. So just going to explain the layout to you. So in the left-hand column, you've got your PEWS score or your trigger criteria. So you can see here they're set in there, those levels of escalation, the low, medium, high, and emergency. You've then got a column of how frequently you're going to be monitoring that child based on these parameters. The next one is if they did need a medical review, how quickly we'd expect that medical review, so the ACPs coming to see the child. And then this is the clinical response, what we would like to see happen for those children that sit in those domains. So for example, this child has a PEWS of 0. We're going to do one set of obs on triage, and then we're going to do them 2 hourly thereafter. We might choose to discuss with the nurse in charge if we're concerned at all about this child. We're going to observe the child in the department, and if the healthcare professional or the parent is concerned before the next set of observations, then we will reassess that child. So I'm not going to take you through every box of this escalation pathway. There's just a couple of points to note. The PEWS does score a lot higher than your previous PEWS score that you were using. So you might have children that are sitting often in the 1 to 4 section, and you might even be discharging some children in the 1 to 4. So just make sure that your ACP is happy and has seen the child before if they are going home with a PEWS score sitting in the 1 to 4. For the high and emergency, these children will need transfer to Colchester to be reviewed by the paediatric team. So just please make sure you discuss these children with the paediatric registrar. Call 999. If you are unable to contact the registrar and you suspect that the child is acutely unwell, then please manage your patient's conditions appropriately whilst awaiting the transfer, but don't delay that treatment or transfer. And also consider for these children sitting in these domains contacting the paediatric consultant at Colchester. So in summary, National PEWS will be coming to Clacton UTC this year, so 2025. All staff caring for paediatrics need to complete the NHS England PEWS e-learning, which is available via ESR. They also need to either watch this online training video or attend a face-to-face session. These will be arranged in due course. So a few things to take away from this session is you will have your PEWS laminated charts available for you to reference in Clacton UTC. From these, you need to calculate what the child's PEWS score is and then put it clearly documented within the UTC notes on triage. There are 4 age-specific charts and each chart has a different set of parameters, so please make sure you choose the right chart for the age of the child. Once EPIC is in place in October, PEWS will be built into the system, so you will use National PEWS on EPIC. Any child that has a PEWS of more than 13, this is a medical emergency and 999 needs to be called for these children. We can escalate the child based on their PEWS score, but also we can escalate them if there is a specific concern. So this means anything to do with any changes in their AVPU or any concern that they are septic, if there is clinical intuition, or if there's any carer concern. And just to note as well, the ambulance service do not currently use the same PEWS scoring system as the national PEWS, so you need to be clear what level of escalation the child is in on handover. Thank you very much for watching this video. Any questions, please direct them to your manager of your area, and good luck with using National PEWS.